talk. And I would also request you all to mute yourself during the talk. Over to you, Dr. Arjun.
So good evening, everyone. Thank you, Dr. Nishant, for the introduction. So I purposely changed the topic from cow's milk protein allergy to mammalian milk protein allergy. This is to emphasize the point that cow milk protein allergy is actually a misnomer. Not only cow's milk, but even goat's milk, sheep's milk, and even donkey's milk can cause protein allergy. So the better terminology would be mammalian milk protein allergy. So this is going to be the outline of my talk. So the first slide is on the difference between food allergy with food intolerance. Now, allergy is an immune-mediated adverse reaction, which is most commonly due to milk, soy, peanuts, and fish. This is in comparison to intolerance, which is a non-immunological response or non-immune-mediated adverse response. Most common of which is secondary lactose intolerance, which we see in post diarrhea in our kids with post diarrhea, which is due to deficiency of digestive enzymes. Now the prevalence of food allergy is increasing. Now studies from 16 countries have shown that the prevalence of food allergy is around 3% to almost 10%. Now this is food challenge proven allergy in children less than 5 years of age. In older children also, the prevalence is quite high, almost up to 3%. This is proven food allergy. And also, this study from UK showed that there is a dramatic response in children who present to emergency rooms with anaphylactic reactions. From 4%, it has increased to 22% over the past decade. This shows the increasing trend of allergies and increasing burden of allergies. Of course, from India, there is no epidemiological data regarding prevalence. However, a study did show that 35% of all children who are hospitalized for chronic diarrhea turn out to have milk allergy. And milk allergy is the most common of all food allergies, and Western data suggests its prevalence to be around 0.5 to 3%. Now, as we can see, of all the food allergies, milk allergy occupies more than 25% of the chunk of all the food allergies. The rest of the allergies is due to eggs or peanuts or fish or soy. Now, food allergy immunologically can be classified as being non-IgE mediated, which is the most common. It can be IgE mediated, or it can be mixed. Mixed is the least common. Non-IgE mediated is the most common, which is followed by IgE mediated. Now, examples of non-IgE mediated food allergies include allergic proctocolitis, enterocolitis, or food protein induced enteropathy. Now, IgE-mediated food allergies encompass the anaphylactic reactions which we see after some certain food intakes, and the mixed include eosinophilic esophagitis. Now, all these three categories encompass the milk protein allergy. That means that milk protein allergy can be mediated by non-IgE immunological mechanisms. It can be mediated by IgE, or it can be mixed, both IgE and cell-mediated. The most common of milk protein allergy is food protein induced allergic proctocolitis. Now we'll come to a case which describes the most common non-IgE mediated milk allergy. So we had a child who was exclusively breastfed till 2 months of age, and till 2 months he was gaining weight appropriately when cow milk was introduced at that time, and the reason was that the mother felt that her breast milk was not sufficient. Now, 1 week after introduction of this, the child started passing blood-streaked stools. He was otherwise active, well-looking, alert. Physical examination was normal. His blood parameters was also sent, which showed anemia, but there was no evidence of any infection. His TLC was normal. Stool RM showed RBCs, but stool CS did not grow any pathogenic organisms, and his CRP was negative. So this is a typical case of food protein induced allergic proctocolitis, which was due to cow's milk. Now this syndrome typically presents with mild symptoms with blood and mucus in stools. Stools may be normal to loose in consistency. Onset is within days to up to 6 months of life. Occasionally, it can also be seen in older children up to 9 months of age. And it is one of the most common causes of rectal bleed. Now, diagnosis of this syndrome is clinical and is based on response to elimination diet followed by an oral challenge. Now, we can have two scenarios in this case. Either the child is top fed like our child, or a rarer scenario is that the child is exclusively breastfed. In a child who is top fed who presents with these symptoms, we have two options: either to reintroduce exclusive breastfeeding like we did in this child. In this, the mother is encouraged to stop the top feed and reintroduce the child to exclusive breastfeeding. However, if the mother is not producing sufficient milk or her breasts have dried up, we can shift the child to extensively hydrolyzed formula and look at the response. Now, if the child is breastfed, we ask the mother to eliminate all milk and milk products from the mother's diet. Response is typically seen within 3 days of dietary elimination, and complete response takes 2 to 4 weeks to happen. Now, the goal challenge is to reintroduce milk after 2 to 4 weeks of eliminating the milk. So, this is usually done in the hospital setting. Initially, 1 ml of milk, then gradually 30 ml, then 10 ml, then 100 ml every 30 minutes is introduced, and the child is observed for 2 hours. If there are no symptoms, then the child is discharged with the advice to give around 200 ml of milk per day. However, if the initial presentation of the child was severe, then the introduction is even more graded. And we start with 0.5 ml, then 1.5 ml, then 5 ml. That is half of what is the standard recommendations of introduction. So if after the oral challenge, the symptoms reappear, that confirms that the child had cow milk allergy. And then we continue with the elimination diet. Now there is the COMIS score, that is cow milk related symptom score, which is an indicator towards cow's milk allergy. It is in no way a diagnostic test because diagnosis requires elimination and then reintroduction. However, symptoms such as crying, regurgitation, stool consistency, skin and respiratory symptoms may indicate that the child may have cow's milk allergy. The total score can be 33, and a score of more than 12 suggests that the child may be suffering from cow's milk protein allergy. So it is a useful screening tool which can be used in the OPD. So coming to the role of other tests, food-specific IgE or skin prick tests are not recommended because usually they are negative, as most common allergy is non-IgE mediated as opposed to IgE mediated. Now, sigmoidoscopy is also not recommended because it gives up non-specific findings such as rectal erythema, ulcerations, or nodular hyperplasia, which can be seen in infections also. Biopsy will show presence of eosinophils with eosinophilic abscesses, which is described as eosinophilic colitis. However, they are non-specific and non-contributory towards the diagnosis of milk protein allergy. Now, the intact protein is the most allergenic, and the least allergenic is the amino acid base, that is completely broken down protein. However, the palatability of the milk also decreases. If you have tasted amino acid based formula milk, you'll realize that it is very difficult to swallow. It is actually quite bitter. And the cost also increases. As the protein is extensively hydrolyzed, the cost of the formula becomes higher. So the ideal hydrolyzed formula which should be used in these children is an extensively hydrolyzed formula. The examples of which include Aptamil Pepti. Sometimes the availability of these formulas is an issue, but earlier it was an issue, but right now that issue has been solved and it is now available. Now the role of soy milk in milk allergy. Instead of giving these children hydrolyzed formulas, can these children be started on soy milk? So I'll be discussing this with a case scenario. We had a 3-month-old exclusively breastfed child presented with frequent loose stools with occasional blood tinged. He was diagnosed as to be having milk protein allergy, and mother was advised elimination of all animal milk and milk products from her diet. And when we advise this, we also supplement the mother with calcium because to ensure that she gets a decent calcium intake. Following this, there was a resolution of symptoms and the child was asymptomatic for around 1 to 2 weeks. And however, later on in follow-up, the child again started having loose stools. So his tests were done, which showed no evidence of any infection. His TLC was normal, stool RM was normal, stool culture did not grow any pathogenic organisms, and inflammatory markers were also negative. So on detailed history, it was revealed that mother had started consuming large amounts of soy milk to compensate for elimination of cow's milk. So there is almost 30% overlap between mammalian milk and soy milk allergy. So almost 30% of those who have allergy to cow's milk will also be allergic to soya milk. And that is why soya milk is not preferred. In the latest ISPACAN guidelines for management of cow milk protein allergy, they mentioned that soy milk should not be used. However, as it is cheaper, in our resource limited settings, we can consider a trial of this if the child is more than 6 months of age. In this child, symptoms resolved on shifting to extensively hydrolyzed formula. So the guidelines are that if on breastfeeding, the child develops cow milk protein allergy, and we have to eliminate two things from the mother's diet, that is animal milk protein and soy milk, then it is advisable to shift to extensively hydrolyzed formula. So another manifestation of non-IgE mediated cow milk protein allergy can be food protein induced enterocolitis syndrome. So we had a 2-month-old baby who presented with repeated vomitings for 2 days, loose stools, lethargy, not accepting well. He was formula fed and via bottle. So initial conclusion was that he had sepsis. On presentation, he was in shock. He had feeble pulses. He had tachycardia with tachypnea with prolonged capillary refilling time. His lab parameters showed anemia with increased TLC, thrombocytosis, raised CRP, raised urea creatinine, suggesting dehydration. However, cultures did not show any growth. So he was initially managed as a case of sepsis. He was kept NPO. Broad spectrum IV antibiotics were started. Fluid resuscitation was done. Oxygen supplementation was done. And PRBC was transfused. And he showed a dramatic response and recovered in 5 days. And all this while he was being kept NPO. On the day of discharge, he was started formula feeding again. And again in 3 days, he returned with a similar picture with repeated vomitings, loose stools, and lethargy. This time, even immunodeficiency workup was done, which turned out to be negative. The child was admitted and discharged, and again admitted and discharged repeatedly before a diagnosis of cow's milk protein allergy was made. What happened was that as soon as he had these episodes, he was admitted, kept NPO, fluid resuscitation was done. And because he was kept NPO and his cow's milk supplementation was stopped, and that is why he improved. So this food protein-induced enterocolitis syndrome can present acutely with profuse emesis, diarrhea, and shock soon after introduction of cow's milk. And it resolves also as dramatically when cow's milk is stopped. It also has a chronic presentation where the child will present with repeated vomitings with failure to thrive. It occurs very rapidly, around 1 to 6 hours post ingestion of cow's milk. A diagnosis is again based on symptom elimination. And as discussed before, IgE levels and skin prick test may not be contributory. So in this case, directly starting the child on amino acid-based formulas is preferred over hydrolyzed formulas because this is a life-threatening situation. And if the child also reacts to hydrolyzed formulas, that can lead to further complications. So in this case, we prefer to start the child on amino acid-based formulas. So examples of which include Neocate LCP. Now, the difference between these three non-IgE mediated syndromes, that is food protein induced enterocolitis syndrome, which is the most severe manifestation, then food protein induced allergic proctocolitis, which is the least severe manifestation. And then we have another food protein enterocolitis, which is a protracted or chronic manifestation is in the symptoms itself. As stated before, allergic proctocolitis will present with blood-streaked mucus containing stools, but the child would otherwise be active, playful. In enterocolitis syndrome, the child will have, in the acute episodes, repeated vomitings, repeated diarrhea, loose stools, and can even present with shock, and is a close differential for sepsis. Sepsis obviously is more common. Diagnosis is again based on clinical history, strong index of suspicion, and resolution of symptoms when we change the type of milk. And prognosis is good. In food protein induced allergic proctocolitis, the child outgrows the allergy by around 1 year of age. Same in case of food protein induced enterocolitis syndrome, and the child may outgrow the symptoms by 1 to 5 years of age. In fact, food protein induced allergic proctocolitis is such a mild syndrome that the recent ISPAGAN guidelines suggest that we do not even need to change the milk. We can continue the same feed and counsel the parents that the symptoms will resolve as the child grows. And this is also due to the risk of non-IgE mediated allergy turning into IgE mediated allergy later on when the milk is reintroduced in such children. So now coming to IgE mediated, these three were examples of non-IgE mediated milk allergy. So how will IgE mediated milk allergy present? So a 3-month-old child with history of seborrheic dermatitis, again repeated loose stools, not gaining weight, with history of asthma and allergic rhinitis, with family history of these two, asthma and allergic rhinitis, suggesting a genetic predisposition, that is atopy. So lab parameters did not reveal any significant abnormality. There was, apart from CRP, which was high, a cow milk IgE was also done, which was very high, 15. So he was started on extensively hydrolyzed formula, suggesting due to with a different suspecting IgE mediated allergy, and the child showed recovery. So at 6 months of age, the grandmother started complementary feeding, and she insisted on starting it with curd. Although they were counseled not to start any milk products, however, the grandmother had this notion that complementary feeding has to be started with giving curd. So immediately following this, the child developed angioedema. You can see the lips swelling and wheezing, and he presented to emergency and required adrenaline and IV fluids resuscitation. So the difference between IgE mediated and non-IgE mediated is that IgE mediated would show immediate reaction. When you give the child milk, within 1 hour, the child will develop symptoms. And symptoms include not just skin and GI symptoms, which are more common in non-IgE mediated, but also respiratory symptoms like wheezing, which this child had. And we can also find a family history of atopy more commonly in IgE mediated as compared to non-IgE mediated. Now, IgE mediated is also different from non-IgE mediated in that it persists beyond 1 year. Now, non-IgE mediated kids usually develop tolerance to milk protein by 1 to 2 years of age. However, IgE mediated may persist longer. And it also has a specific role of IgE and skin prick tests. This I will be discussing later on. So treatment, as this child had severe symptoms and anaphylactic reaction to milk, he was restarted on extensively hydrolyzed formulas. In case the first presentation is of severe anaphylaxis, it is advisable to start amino acid-based formulas because of the lower risk of allergy to an amino acid-based formula. And non-IgE mediated allergy can also convert to IgE mediated allergy as age increases. So now comes the role of when and how to reintroduce milk. The child was introduced to curd at 6 months of age and showed a reaction. So what is the ideal time to reintroduce milk? So the guidelines are that the child should remain milk-free till at least 12 months of age until at least 6 months post stopping of milk. And when we reintroduce milk, it should be a gradual reintroduction. And herein comes in the concept of Indian milk ladder, in the formulation of which Dr. Nishant was also involved. So the first step is to introduce milk in the form of a very small quantity of milk protein, which is cooked at a very high temperature of 180 degrees for a long duration, almost 15 minutes. So this is a Mari biscuit. So a Mari biscuit has a very small quantity of milk protein, which is baked at almost 180 degrees with a prolonged cooking time. This ensures that the milk protein in it is sufficiently denatured. Now, if the child tolerates this, then we move on to step 2, which consists of a larger quantity of protein, which is cooked at a lesser temperature, boiled means 100 degrees, for around a similar time. So in this, the milk protein is not as denatured as it was in step 1. So we can, in this step 2, we can give to the child halwa or ragi or kanji with milk. In step 3, we move on to curd-based preparations such as rava idli or rava dosa, which has a fair amount of protein cooked at lesser temperature for a shorter time. That means it is less denatured now. And if the child is tolerating this, then we move on to step 4, which consists of rice kheer, and then gradually on to step 5, which consists of paneer or yogurt. And then final step is to reintroduce milk. So do not reintroduce milk in one step. You have to go progressively, gradually increasing the amount of milk protein and decreasing the amount of cooking time until we are sure that the child will be able to tolerate milk without any symptoms. So this is the Indian milk ladder. Now, as I said before, what is the role of IgE and skin prick tests? In case of IgE mediated allergy, higher levels of milk specific IgE at presentation or a larger wheal size at skin prick in the skin prick test can indicate persistence of allergy. So there are specific guidelines according to the wheal size and titers of milk specific IgE at which can indicate the time at which we can reintroduce milk. In case of anaphylaxis reaction or the severe manifestations of food protein induced enterocolitis, reintroduction is to be delayed. Now coming to an example of a mixed IgE and cell-mediated allergy. So we had a 1.5-year-old child who presented with repeated vomitings, weight loss for the past 3 months. His hemogram showed elevated eosinophils. The rest of the tests were normal, particularly uh, test for celiac were negative, which is the most common differential if you get a child with these symptoms. So this is the child. You can see that he was emaciated, uh, not well thriving. So in this child, because of repeated vomitings, we did an endoscopy, which showed a typical trachealization of esophagus with a tram track appearance. A skin prick test was also done, allergic to milk. The biopsy showed infiltration of eosinophils in the mucosa, which is diagnostic of eosinophilic esophagitis. So the treatment is that milk was eliminated from his diet. So current studies show that a single food elimination is as effective as 6 food elimination in majority of the patients. So on eliminating the milk and starting topical budesonide, the child had a dramatic improvement, and this is the same child 3 months later. You can see that he has gained weight. So in pediatric patients, eosinophilic esophagitis presents with vomiting, abdominal pain, and weight loss. In adults, dysphagia and food impaction is the most common manifestation. The remarkable thing about is that it has a delayed onset of symptoms. Now, both IgE and non-IgE mediated will present early. Now, this will present late. So this child came to us at 1.5 years of age. We even have children of 4 years and 5 years with eosinophilic esophagitis due to milk. And these symptoms will not resolve with age, in contrast with IgE and non-IgE mediated. And if severe, they may require amino acid-based formulas also for milk. So now coming to the topic of prevention. So we know that in the initial period of life, allergy will present as food allergy and atopic dermatitis, which usually involve the GI and the skin. And as life progresses, these children are more prone to develop respiratory symptoms, allergic rhinitis and allergic asthma. So a lot of research is being done to prevent this allergic march. However, no specific therapy has yet been identified. At-risk infants, studies have shown that this infant with the family history of atopy do not benefit from partial or extensively hydrolyzed formulas. So there are no guidelines which suggest that these children should not be breastfed. The current guidelines are that at-risk infants with first-degree relatives should be continued on breastfeeding. And there are no guidelines to delay introduction of animal milk in these babies as well. So do not delay introduction of high-risk food beyond 6 months in these children, including animal milk, because they do not benefit the child. And desensitization, now milk allergy resolves on its own. So no desensitization therapy is usually recommended. So by around 2 years of age, the milk allergy in most of the children resolves. Other food allergy, including peanuts or tree nuts, that persists longer. And for that, we have desensitization therapy, and good work is being done in our pediatric allergy department regarding this. So to recapitulate, in a breastfed child who presents with symptoms suggestive of cow milk allergy, the mother should be on a cow milk free diet along with calcium supplementation for 2 to 4 weeks. And if the symptoms disappear, then a reintroduction or an oral challenge should be done. And if symptoms reappear, that confirm the diagnosis of cow milk allergy, and following which we need to eliminate all cow milk sources. In a formula fed child, the child is shifted to an extensively hydrolyzed formula, and if the symptoms improve, again reintroduction of cow milk should be done. And if the symptoms reappear after this introduction, that confirms the diagnosis of cow milk allergy. In a formula-fed child with severe symptoms and anaphylaxis, instead of extensively hydrolyzed milk formula, directly amino acid-based formula should be started. And if the symptoms improve, then yes, the child is diagnosed as a cow milk protein allergy. Reintroduction or re-challenge is in severe symptoms is not done because of risk of anaphylaxis. So in summary, food allergy is increasing, and the most common is mammalian milk allergy. It can be non-IgE mediated, which is more common, or IgE mediated, which is less common, or mixed. Diagnosis is by elimination, and role of food-specific IgE, like milk-specific IgE and skin prick test in IgE-mediated allergy alone, not in non-IgE mediated. And treatment is by elimination of milk from mother's diet in breastfed children, extensively hydrolyzed formulas in formula-fed children. You need to remember to supplement calcium and vitamin D. And milk allergy is usually self-resolving. And during reintroduction, we need to follow the Indian milk ladder. Thank you.
Thank you, Dr. Arjun, for an excellent overview of bovine milk protein allergy. I would welcome questions from the audience. If there are any, you can post them in the chat box. We have 42 participants here. So, Dr. Meena, welcome. We started without you. Apologies. So, we have just finished the topic. You have any questions, you may please join the discussion.
In the chat box, any questions? I think no one question raised.
No questions as yet in the chat box.
I
So,
think
Dr. Arjun, if a child who has milk allergy and he's been otherwise on exclusively milk-free diet, he comes to you with symptoms typical of milk allergy. So what all would you like to ask? Where exactly could be the hidden source of animal milk in the diet of this child? say a 4-month-old child?
So even if the child is using a soap which is milk based, so that can also lead to the symptoms. Of course, the mother if she is consuming milk, that can small amount of it can be excreted into the breast milk.
And skin
Skin.
is also one of the
Yeah.
areas
So
where
if they are using a milk-based soap,
many families have this tradition of bathing the child with milk or using ghee or butter to remove the body hair of the child. So that can lead to sensitization and typical features of GI manifestations of bovine milk protein allergy as well. So in a child who's been otherwise totally milk free, these could be possible problems. We have a question in the chat box. Which animal's protein is most allergenic? Which animal's protein is least allergenic? So is there something like difference in allergenicity of milk protein based on from animal to animal?
so it is said that donkey's milk is least allergenic and cow's milk is most allergenic.
Okay. So, and but I would just like to say here once that uh, the treatment of bovine milk protein allergy is stoppage of all forms of bovine milk protein. So one should not start looking for the least allergenic bovine milk as a treatment, because this is purely of academic interest rather than treating of therapeutic benefit to a child. So there's a question, please, sir, please tell me the name of the hydrolyzed formula available in the market, in Indian market, I believe. Yeah.
So I had a slide on it, so I can go back. So
So,
Aptamil Pepti is the extensively hydrolyzed formula which we use commonly in our setup. So it is usually available, yeah.
yeah. So there were 3 companies which were initially manufacturing
Now
hydrolyzed formula,
Aptamil Pepti is there.
Abbott, and so now 2 of them are no longer supplying the hydrolyzed formula. So we now have only the option of Aptamil Pepti. Dr. Meena, who is the head of department at RML Hospital, sir, would you like to ask any questions or join the discussion?
Actually, Dr. Arun nicely covered with the whole clinical scenarios. My message to house that the cow milk allergy is not uncommon in the even Indian populations. It's quite common, but many of the times, especially in the some pediatrician, overdiagnosed by the emphasis on the skin prick test like that. Because this one is a majority of the GI manifestation usually like the non-IgE or mixed type presentations. So don't rely on the skin prick test. There are some specific particular recommendation or guideline. We should follow that. Especially food elimination is one of the easily available test that recommended by the various societies for the diagnosis of the cow milk protein allergy. If the child is responded well, then we should reintroduce the food after certain of the time of the period, like the 4 to 6 weeks. Then the reappear of the symptom, then we can confirm the diagnosis. Second thing, although the percentage is quite small, around 10 to 15% cases also show the cross reactivity, especially like the Dr. Arjun already said, like the soya proteins. Those children have the cow milk protein, also have the soya protein allergy. But in that situation, we should take the very carefully and offer the non-soya protein based formula foods. And usually in our setup, soya formula based food material is easily available, and we commonly advise in the cow milk protein allergen kids. In that situation, because soya is one of the culprit cause the malabsorption of the calcium, so that kids require the calcium supplementation. And third thing, FPIES. FPIES is very widely variable, and it is just like the medical emergency, because majority in the FI, those are the kids percentage of the acute crisis like moment, like the child have the severe vomiting, dehydration, shock-like episode that usually behave like the fulminant sepsis. Yeah, definitely by the supportive treatment that kids partially responded, but they need the proper workup for the additional rule out the underlying sepsis along with dietary management, like the especially formula foods. These are the important things because FIs usually percentage is the significant growth failure along with crisis-like episode. So this child has a very high mortality. So that child first need the registration by the fluid and electrolyte rehabilitation, followed by the specific treatment.
Thank
And
you.
you said eosinophilic esophagitis. Definitely, these are the also upcoming very frequently reported available data from the Indian population also. Yeah, for that only diagnosis is just like the food elimination. Along that need the particular treatment like the soya-based or non-milk diet that quietly respond very good and need the regular follow-up. And dietary counseling, one of the difficult tasks regarding the cow milk allergen patients as well as parents, because majority of times, as Dr. Nishant already highlighted, they are the thinking only milk required the stop. But even if the mother giving the continuous mother getting the continuous milk in their own diet and continue the breastfeeding, that also cause the persistence of the symptoms. And second thing, even in the minor exposure like the child getting the butter without getting the significant amount of the milk also persist the symptoms. So that counseling is very elaborative and need the more detailed repetitive counseling for that dietary elimination. That is very important. Otherwise, majority of time we advise the formula feed and child not responded. Parent lost the faith from the clinician because we are not giving the proper counseling for the parents. So that is very important also. Even after diagnosis, child is not responded because the contamination of the milk product. That is very important.
Thank you. Thank you so much. I have a couple of questions in the chat box. What is the ideal age to start cow or buffalo milk in an infant? Dr. Arjun?
So exclusive breastfeeding is recommended till 6 months of age, and after that, we can introduce cow's milk or buffalo milk. There are no recommendations to restrict or delay in children who are at risk or who have family history of FOP. So,
yeah. There's a question which is asking you to share the slide containing amino acid based formula feed.
yeah, so I have done that.
Yeah, so I think you can share it in the chat box, or you can post your number and we can share the PDF of this presentation to all of the people who are interested through WhatsApp or email. We would be happy to share it.
Email ID and
yeah.
number
So,
is on this slide.
yeah, so just show your contact slide and that should be it. We will share everything. As regards the ideal age to start animal milk in infant, this question is tricky because technically and ideally, because you're talking about the ideal scenario, a child should never be on animal milk at all. It is the animal milk products which are gradually introduced in terms of ghee, butter, paneer, dahi, etc. And that was the tradition even in our own country. So in our own country, if at all the breast milk was not available several years ago, then there used to be a concept of daima, and who would be the lactating uh, mother who would actually feed the child if the biological mother was unable to feed the child. And that used to be something people would look for in around their villages, who would then they would not actually feed cows or buffaloes milk to their children. That was the tradition actually in Indian tradition. And it was the butter or ghee which used to be introduced in the diet of infant around about the time of complementary feed introduction. So I think there is a scientific concept behind that as well. And it has been there for ages. There have been people who have, I remember almost 20 years ago when we started, I gave my first lecture on this topic. One of the first questions which the audience asked came from the audience was that how can a country like India, you can have children with cow's milk protein allergy, wherein cow's milk has been used for ages in this country. So that actually the explanation, when I looked at literature, I found this answer that actually cows and buffalo's milk was not fed to infants in the first year of life. It used to be either the breast milk, or people would look for a mother who would. And I'm talking of as old as our ancient text. And we know that even Krishanji was, she was shifted, and he was actually fed breast milk. And the first animal milk product which he had was makhan, as we know. So just so there is really, we in traditionally speaking, we do not introduce animal milk in the diet. We introduce animal milk products in the diet of the child. And I guess the concept here is that allergenicity of animal milk products is much less than pure animal milk as such. So I think that's how we should be going about it. And there's another question. If we introduce cow's milk or buffalo milk earlier than 1 year, incidence of iron deficiency anemia is more. Dr. Arjun, is it so?
Yeah. So the quantity of milk is to be restricted. So in Nelson, I think it says that more than 400 ml of milk is associated with anemia. If we give cow's milk of more than 400 ml in child who is more than 1 year of age, then that is a risk factor for anemia. So that is true.
So the amount of milk is important. If you are feeding 1 liter of milk, which is a quite common practice in India, in the northern part of India, Haryana, Punjab, Delhi, etc., UP, even Rajasthan, then the chances of iron deficiency anemia are much, much higher. So, and it's purely due to excessive milk intake leading to iron deficiency anemia, excessive milk intake leading to constipation as well, then lack of toilet training, loss of blood in the stools, occult blood losses. So there's a real vicious cycle leading to iron deficiency anemia. So the amount of milk has to be kept. So beyond 1 year of age, do not feed the child more than 300 to 350 ml. That should be the goal in 24 hours. So I think we've answered most of the questions. If we don't have any further questions, Dr. Meena, if you have anything to add up, or we will just sum up the lecture today.
Dr. Arjun, how you advise about the specific IgE mediated test when we are the suspecting cow milk protein allergy for the pediatrician?
So usually it is very rare. Most of the cow milk allergy are non-IgE mediated. So usually we don't recommend this test. In literature, it shows that those who have IgE mediated with a family history of atopy, or in those, this test can be used to identify when cow's milk protein can be reintroduced. So if there is a high titer, then reintroduction of milk can be delayed as compared to, so actually stratify the titer and the risk of having recurrence of symptoms when milk is reintroduced. So that I think is the only use, but clinically we rarely use it.
Message to house, those are the kids usually present like the non-GI manifestation, especially ocular, GI, respiratory or dermal. In that situation, it might be helpful, but due to the low specificity and low positive predictive value, it's not recommended usually by the guidelines.
It's like MON2 test. A positive MON2 does not mean that the child has tuberculosis. Similarly, a positive IgE does not mean that the child has milk allergy. Or a negative IgE does not rule it out.
And another is cow milk COMSS, cow milk
score.
That is also not very good useful in the day-to-day practice, but is maybe useful in the clinical settings like the OPD practice. We can skin of the children's. Those are the suspected for the cow milk. And then later on, we can give the food elimination test and we can verify the diagnosis.
So it is an indicator, usually for OPD practice, and for research purposes in studies, it has been used to stratify the response to elimination.
But majority of the points also including in this scoring is respiratory or dermal manifestation. So those are the cases percentage as a non-GI manifestation. In that situation, it might be low scoring.
Sure, sir.
So I would just like to thank everyone, Dr. Shyam Meena, Dr. Arjun, our audience here, the participants who have asked us some really good questions. And if you have any further questions or queries, Dr. Arjun's contact email and number is there on the last slide. Please note it down and we'll be happy to answer all your queries. Do contact us. Thank you so much. On behalf of IAP Delhi and on behalf of Sir Gangaram Hospital, I would like to sign off. Good night.
Thank you. Thank you,
Good night.
doctor. Thank you.
Thank you.
Have a good day.